Okay, Chapter 12, Extraoral and Intraoral Examination. Our objective for this chapter is to explain the rationale for comprehensive extraoral and intraoral examination. And that would be to observe and record deviations from the normal. Of course, you have to know what normal is before you can explain a deviation, right? And to screen to detect lesions in the oral cavity and on the neck and face. To recognize the need for a changing care plan. If a patient has a communicable disease or needs a med consult, we want to make sure that that is done at the beginning of the appointment, and that they're recognized at the beginning of the appointment. And so we actually do the EO-IO before we start any treatment. Okay. Recognize development of advanced, irreversible, or untreatable oral diseases. All right, we want to recognize, oh, that's on there twice. Okay, identify conditions requiring testing. So do they need to be referred for a biopsy, or can we just do a little brush biopsy in the dental office, or do they need to go see their physician? It also helps us provide a baseline for later comparison and provide legal documentation for patient's diagnosis and treatment plan. Okay, so the current concept in oral health care and patient care is that the whole patient is being treated, not just the oral cavity. We want to look at the patient as a whole, all right? Make sure you aren't just so focused on the teeth or so focused on the gums that you forget there's a whole body connected to that individual, those teeth in that mouth. Physical exam, we're going to look, examination is all-inclusive. So we're looking at the physical, the mental or psychological influences of the patient. How motivated might they be if there's something wrong with one of those three components, right? Say somebody just passed away. Are they going to be motivated to take care of their mouth? If they aren't motivated to take care of the mouth, then how is that going to reflect on the rest of their body? So we're kind of looking at it holistically, okay? All right, so after studying this chapter, you should be able to explain the rationale for the comprehensive extra and intraoral examination, explain the systemic sequence for the EO-IO exam, identify normal, hard, and soft tissue anatomy of the head, neck, and oral cavity, and then describe and document physical characteristics such as the size, shape, texture, consistency, and the morphological, the shape, right? So the morphological categories such as elevated, flat, depressed lesions for any notable findings. So one objective is that we're going to recognize normal anatomy. So then, of course, our last objective is going to be to identify the suspicious conditions. And we need to know normal before we can know if it's a suspicious condition, right? Okay, so what is our rationale for the EO-IO exam? The EO-IO exam is performed for early detection of abnormalities and pathologies to hopefully prevent the spread of the disease or the cancer, okay, or condition. Although an essential goal of the examination is to detect cancer of the mouth at its earliest possible stage, a thorough examination may also reveal signs of thyroid disorders, eating disorders, nutritional deficiencies, sexually transmitted diseases, and a host of systemic conditions. All right, so we have different types of examinations. We have a complete examination, and that includes a very thorough summary of all of the components of the assessment. So that's including our probing, our dental charting, our EO-IO exam, TMJ examination. So many components to a complete examination. And this is going to be performed on all new patients and then at each routine continuing care visit, which is where they see the hygienist, right? And then we have screenings, and screening just implies a really brief preliminary examination, usually for a particular purpose, such as pain relief or an initial patient assessment during triage or to determine priorities of treatment. Then we have a limited exam, and this is actually coded differently, a limited exam. And a limited exam is a type of brief exam for emergency situations. And this could be used for the management of a periapical abscess or a periodontal abscess, something like that. So it's limited to emergency or palliative care. Then we have our follow-up exam, and this is just a check on the healing following treatment. So we have a follow-up in dental hygiene care, and that's after we do scaling and root planing. They come in 6 weeks later and we reassess. Okay, check to make sure that they're able to reach their goals of home care. Also check for healing response. Check for any bleeding, anything that may have healed, or their OHI also. All right, continuing care, maintenance after a specific period of time. So if they did have the scaling or planing, it would be 3 or 4 months. Otherwise, our normal healthy patient is going to be every 6 months. Okay, now method of evaluations. Well, we have the visual examination, and that is direct. Okay, we're seeing this. So we're looking at radiographs, we're looking in the mouth. We can use transillumination. That's when you use light through like a tooth, okay, but you're still seeing it. You're using the light, but you're still using your eyes to detect it. All right, then we have palpation, and there's multiple different ways of palpating, and I believe this is a question also on your worksheet. We have digital, and that's the use of a single finger, okay? So this could be applied to the mandible beneath the canine and premolar areas to find if there's any tori there. It can also be used to find the mental foramen when you're looking to do a certain injection. Then we have bidigital, and that's when you're going to use a finger and a thumb, and you kind of put one on the outside, so say the thumb on the outside and the index finger on the inside, and you're palpating the lip, okay, to feel for anything abnormal under the tissue there. So bidigital, 2 fingers. Think digital, finger. Bidigital, 2 fingers. All right. Now, bimanual is the use of fingers or fingers and thumb on each hand. So manual, think hand. 2 hands, bimanual. Okay. And so you're going to be using the fingers there, and that's if you're checking the submandibular gland or the sublingual gland. You're going to push up on externally, so under the chin. You're going to push up and then take your fingers on the other hand and go in the mouth under the tongue and push down, and then you can feel that gland and if there's any irregularities there. Then we have bilateral. Lateral meaning side, right? So a hand on each side. This is used to check the TMJ and also to palpate the chin for the submandibular lymph nodes. All right, now we have instrumentation. And that's using things such as a probe or an explorer. Explorer is used to detect decay for the most part, tooth irregularities, okay? And then our probe is used to measure pockets, to measure attachment loss, multiple things. We'll get into that more later. But an instrument is considered your probe and your explorer. Then we have percussion examination, and that's where you're tapping on a tooth to see if there's any sensitivity. If the patient says, whenever I bite down, I think it's this tooth, you could use an instrument and just kind of lightly tap on the tooth and say here, here, as you're tapping, and that will kind of narrow it down for you to determine which tooth is actually bothering them. Then we have the electrical test, which is a pulp test, and they put it on the tooth, and there's a normal range where they should feel some tingling there. It's not painful unless the pulp is diseased. So we can have a hyperreaction where you barely turn it on and they're jumping out of the chair. Or you can have a hyporeaction, which is where they turn it all the way up and the patient doesn't feel a thing. And that means that the nerve has died. Okay. Then we have the oscillation test, and that is sound. So you might hear the TMJ clicking. Also, if you think of your blood pressure stethoscope, when that's going to be using oscillation, right? Because we're using our ears to hear that tapping. Okay. Okay, now we're just going to go through some of that palpation, and here is the bidigital, checking out the lip. Here's our bimanual, so they're using two hands. If you look in B, that's where I'm talking about. You're checking that it looks like they're looking at the sublingual or submental gland there. And here's our TMJ. We're going to use bilateral palpation here, but also we're going to be listening, right? That auscultation. I'm pretty sure I'm saying that wrong. I'll have to look that up again. All right, signs and symptoms. All right, so prepping for the exam. First, you want to review the patient's medical, dental, and social histories. You want to examine the radiographs to check for any pathologies there, any decay or bone loss. And then we want to explain the procedure and what we're going to be doing to our patient. Okay, so I'm going to perform an intraoral exam today to look for any abnormalities. We never say for cancer. To look for any abnormalities that can affect your oral and overall health. Do you give me permission to proceed? Okay. You don't just tell them you're going to do it. You also have to ask for permission. All right. And then we just want to remind you to always be culturally sensitive. Be sensitive to cultural or religious practices, such as wearing a scarf or a burqa, a hijab. Ask them before feeling under there or moving it at all. Some say, no, I don't want you to remove it. Others say, yeah, that's fine. And I just work around it. So I can feel things on the head, but, ultimately I do just have to lift it up a little bit for the ears usually. And I always get permission first. You must always get permission first. Okay, now let's talk about the oral mucosa. And we have three types: masticatory, lining, and specialized mucosa. Remember, our masticatory mucosa is that really tough mucosa that's waterproof. So that is it's not movable. So that's going to be what's attached to the bone, right? So our gingiva. And no, that doesn't include the free gingiva. Okay. Well, I shouldn't say that. It does include the free gingiva, but the free gingiva is the only part that isn't attached. Okay. So our masticatory mucosa is just firmly attached. That's how I want you to think of it. And then our lining mucosa is kind of what lines our cheeks and our lips, underneath our tongue. Okay. It's that really thin, non-keratinized mucosa. Okay, so it's loose, it's movable. It needs to stretch to hold things and to move, right? Then we have our specialized mucosa, and that's basically on the surface of our tongue, right? That's going to be our taste buds and just basically the dorsum of the tongue. All right, I do want you guys to make sure you review this. I can't stress that enough. You need to know all of these landmarks prior to pre-clinic this summer. So put this somewhere, keep reviewing it. You need to know it now also, but make sure that you are reviewing this on a regular basis. Okay, now the sequence for the examination, it's important that you have a sequence so that if you get interrupted or, you're thinking about something else, that you don't miss anything, okay? So first you're going to just kind of look at the patient. You're going to notice, okay, this kind of starts from the moment you bring the patient back, right? You're assessing their gait, you're watching their movement, listening to the way they're talking. And then you're going to start with the face. Is anything drooping on one side or the other? Look at their skin. Do you see any lesions on their skin? Their eyes. Then you're going to go check their lymph nodes, and we're going to have a picture of that coming up here. You do need to know the different lymph node chains. And then you're going to check the glands, and then you're going to slip your hands up to the TMJ and then to the lips. Now, this sequence, this is what's recommended by the ADA and the National Cancer Institute, or I shouldn't say the ADA, the National Institute of Health and the National Cancer Institute. But I don't use this one. I always start with the skin and face, eyes, and then I do the TMJ down to the glands, and then now we're going from the extraoral and working our way intraorally. Now you're going to note their breath. Is it really sweet smelling? Could they have hyperglycemia? Or is it kind of musky? Have they been drinking? Okay. Or does it smell like periodontal disease? All right. Then we're going to start checking the labial or the lip mucosa and the buccal or cheek mucosa. Then we're going to evaluate the tongue, and we're going to do that by actually pulling the tongue out. We're going to palpate the tongue. We're going to pull it to one side, check the lateral borders, because that is the most common site for cancer. Then we're going to pull it to the other side and evaluate the lateral borders on that side. Then we have them touch their tongue to the roof of their mouth, and we can evaluate the ventral surface of the tongue and the floor of the mouth at that time. While that tongue is touching the roof of the mouth, we're just going to call it milking the salivary gland, okay? You're just going to kind of try and stimulate the glands there, and then you're also going to do that on the buccal mucosa to make sure that they have adequate saliva flow. Then you're going to palpate the hard palate, make sure that everything is nice and firm and the way it should be, that there's no lumps, bumps, or sores. Then we're going to visually inspect the soft palate and the uvula. That's that. All right, here you can see the landmarks of the oral cavity and the ventral surface of the tongue. And you are expected to know all of these different names for the different features. I was looking for my pen here. I've just had a time with this. It doesn't look like it's going to work. Okay, so I do want you to look for the sublingual caruncle, and I want you to see that and where the submandibular duct is, so that you know where to kind of milk it. Okay, and then notice I'm sorry, I'm really trying to get this pen to work. Notice the lingual frenum, that they're able to touch their tongue to the roof of their mouth. It's not. All right, and here's our our lymph nodes. Please put this picture somewhere, memorize this. You have to know this. Put it in a place that you can review it quickly. You will need to identify each of these lymph nodes. when you're doing the EO-IO skill assessment in both preclinic and in clinic. All right, the extraoral exam, you want to observe the patient during the reception and seating. Again, you know, as they're walking back, do you notice anything abnormal? I recall one time I had a patient who his chin looked like he had something under his chin. Right away I noticed it. You know, he hadn't noticed it growing over the last 6 months, but him seeing me, nor had his wife. My boss was his, and him were really good friends. They were related. And nobody had noticed it. And I felt it. He had a large, hard mass there. And, you know, whatever, we won't go into all that. But it started in the waiting room when I called him back. Okay? So you want to observe their head, their face, their eyes, their neck, evaluate the skin of the face and the neck, request the patient to remove any prosthetics prior to performing the intraoral exam, so any partials or dentures, anything like that that can be removed. Explain how this will improve the ability to inspect all areas of the mouth adequately. If that partial's in there, it's covering the palate, right? So we don't know if there is any pathologies on the palate. Palpate the salivary glands and lymph nodes shown. You can see those in figure 12-8. Again, make sure you know all of your lymph nodes. Palpation is a significant component of the EO-IO exam. Okay, so you're going to note if there's any pain or discomfort as you're palpating the patient. You know, if they say, oh yeah, that's tender, you want to ask them, you know, do you feel any tenderness here, here, here? You know, please let me know. So you want to make a note of that if there is, okay? Also, if there's any pain or discomfort when they swallow, you do feel that thyroid as they swallow, okay? Persistent difficulty swallowing in the absence of pain. So when my brother had cancer, what brought him to the doctor is that he couldn't swallow. His the tumor had wrapped around his trachea. Okay, so you know, I mean, it could be even something like that. If he had gone into the dentist and they noticed that he was having difficulty swallowing, you know, earlier, then maybe we could have caught it a little earlier. But whatever, it is neither here nor there. He's fine now. Any recent noticeable lumps that the patient may have experienced without pain? Okay, so I always say before I get started, you know, I'm going to do this exam to check for any lumps, bumps, or sores is what I say. Have you noticed any lumps, bumps, or sores in your mouth? And then they'll say, oh yeah, you know, this and that, you know, or have you noticed any on your neck or face, you know, that you're concerned about? And the patients are pretty in tune with their bodies. Not as much their mouth, but definitely, you know, their head and neck. Ask them if they've had any persistent earache or hoarseness of the voice. Observe mandibular movements and palpate the TMJ. Is it deviating to one side or another? Is it... All right, so here we have some piercings. We also want to know any piercings in the lip, cheek, nose, or tongue. In fact, in our clinic, we do have you also note it on the ears too, okay? Those can develop infections or can, especially... Okay, we also want to evaluate any scars and make a note of any scars or any facial lesions that they may have, okay? And that may include a referral to a physician. All right, our intraoral exam. Make a preliminary examination of the lips and intraoral mucosa by using the mouth mirror or the tongue depressor. So initially, you're just going to do a really brief, like, can this patient be seen today? You know, if there's sores everywhere, no, right? So just do a really quick evaluation with the mirror. Then you want to view and palpate the lips, the labial mucosa and the buccal mucosa, and the mucobuccal fold, which is right at the top or the bottom there, right? Where it transitions from the lining mucosa to the masticatory mucosa. We want to look right in there, okay? Then you want to examine and palpate the tongue. And you're going to look at both the dorsal and the ventral surfaces, the lateral borders, and the base of the tongue. So you're going to have your patient say, ah, and just make sure everything's okay back there. You want to retract to observe the posterior third. So you're going to kind of pull that tongue out just a little bit, first to one side and then to the other. And we did talk about that earlier. Observe the mucosa of the floor of the mouth. So after you've done that with the tongue, just say, may you please, could you please put your tongue to the roof of your mouth? You're going to evaluate the ventral surface. Then you're going to start to evaluate the floor of the mouth. Examine the hard and soft tissues in the tonsillar area and the pharynx. Use a mirror to observe the oropharynx and the nasopharynx and larynx. Note amount and consistency of saliva evidence if there's a dry mouth. Okay, so if you notice any xerostomia, you want to make sure that that is noted. Okay, so now let's talk about documentation of findings. So history, you want questions directed to the patient to provide necessary information to manage the lesions that are found. Because alarming the patient must be avoided, judgment is needed for selecting the appropriate time to obtain the history of the lesion. So whether the lesion is known or not known to the patient, or if there was a previous evaluation. If known, when first noticed, if it's a reoccurrence, okay? Then you want to know how long they've had it, what symptoms they've had, have they had a fever or sore throat, anything like that. And then changes in the size or appearance. So that is all subjective data, right? The patient is reporting all of this to you. You're questioning them. Now we're going to get into our objective data, which is when the lesion was first seen, the location is noted in relation to the adjacent structures. So this could be subjective, it could be us. It depends on if it's a follow-up appointment, right? Then you want to document a complete description of the findings, the location, extent, size, color, surface, texture, and configuration. A printed diagram of the parts of the oral cavity can draw, so that you can draw where it's located, is really helpful also. So descriptive words to define the location and extent include localized, meaning it's just in a small local area. Generalized, which is, a generalized area, right? It's all over. A single lesion, so is there only one, or is there multiple lesions, more than one? And then is it separate? So is it discrete and not running together? Or is it coalescing, where it just kind of, it's close to each other with margins that merge, okay? So those are really important descriptors, all right? So is everything just kind of running together? Does it look like multiple sores that are running together, or is it one large sore? Where is it located? All right, now the physical characteristics, we're going to look at the size and shape, and we're going to record the length and width in millimeters. All right, that's very important. You guys are going to learn about this in pathology, so I'm not going to get too in depth. Then you want to list if it's, or note if it's heightened or elevated, or if it's indurated, where it goes down into the tissue. Okay. The color, is it red, pink, white, red and white? All right. Other more rare lesions might be blue, purple, gray, yellow, black, or brown. So we want to make sure that we have a good descriptive color. All right. And then the texture, the surface texture, a lesion may have a smooth or irregular surface. All right, most lesions can be classified readily as elevated, depressed, or flat as they relate to the normal level of the skin tissues. So an elevated lesion, we have blisterform. And blisterform lesions contain fluid, so that's a difference, right? Blisterform has fluid in it, okay? So there's a few different types of blisterform. We have vesicle, and that's where it's small, 1 centimeter or less in diameter. What you think 1 centimeter in the mouth, that's pretty big, right? It's a circumscribed lesion with a thin surface covering. All right, it may contain serum or mucin and appear white. Then we have a pustule, and a pustule may be more or less than 5 millimeters in diameter, and it contains pus. Okay, so this is going to give it a yellowish color. So vesicle is going to be white. Pustule is going to be more yellow. And then we have a bulla. And a bulla is large, more than 1 centimeter, and it's filled with fluid, usually mucin or serum. So this is bigger than the vesicle. All right. But may contain blood, and the color depends on the fluid content. Now, non-blisterform lesions are solid. They don't contain any fluid, so they're fibrous, okay? So we have papules, nodules, tumors, and plaque, okay? So the papules, nodules, and tumors are also characterized by the base or the attachment, okay? The pedunculated lesion is attached by a narrow stalk or a pedicel, whereas the sessile lesion has a base as wide as the lesion, okay? So pedunculated is going to be, think of like a mushroom, okay? So it's got a stem and then it gets bigger. All right, sessile lesion is going to be just as wide. It's going to be just a nice firm base for the lesion. All right, so a papule is a small pinhead up to 5 millimeters in diameter, solid lesion that may be pointed, rounded, or flat at the top. Then a nodule is larger than a papule, so it's between that 5 millimeters and 1 centimeter. A tumor is 2 centimeters or greater in width, and it is, in this context, tumor means a general swelling or enlargement. It doesn't refer to a neoplasm or cancer, okay? Plaque is a slightly raised lesion with a broad, flat top, okay? So this would be a sessile lesion, okay? It's usually larger than 5 millimeters in diameter with a pasted-on appearance. And I think that's such a great description because it does look like it is pasted on. All right, now let's look at our depressed lesions. So these would be our lesions that are below the surface of the surrounding tissue. So an ulcer is also a depressed, okay. Most depressed lesions are ulcers and represent a loss of continuity of the epithelium. The center is often gray or yellow. It is surrounded by a red border. An ulcer may result from a rupture of an elevated lesion, such as a vesicle, pustule, or bulla. Okay, so especially like those herpetic lesions, once that vesicle breaks, you now have an ulcer. And then we have erosion, and that's just a really shallow, depressed lesion that that does not extend through the epithelium to the underlying tissue. All right, so it's kind of almost, it just looks like you're peeling that top layer off. Okay, flat lesions, on the other hand, are called macules. So think of your freckles, okay? It's a macule. It's not elevated. It's circumscribed and just kind of part of the tissue. So it may be identified by its color, which contrasts with the surrounding normal tissues. Okay. All right. So here's a single macule, and then regular outline versus irregular outline. We want to make sure that we notice that, right? Look at that. That is not a regular outline. All right, here's a macule on the lip, and you will see those. They can be from sun damage, or they could be a birthmark, okay? And they can't be palpated, so if you press on it, you're not going to feel anything. All right, I really like this slide because I feel like it gives you guys a really good way of working through how to determine what's what, okay? So single, this is for depressed lesions. We have single, multiple, regular outline, irregular outline, smooth margin. So it just kind of lays it all out for you, as does the macule lesions. And this is in your book. All right, and here's our elevated lesions. This is the one that I like to keep in the office, just so I can describe them. The others I can always keep down pretty good, but this is the one I always keep in the office. All right, we already went through this, but blisterform again contains fluid. Vesicle is less than a centimeter. Bulla is greater than a centimeter. The vesicle is going to be either clear or white. The bulla can also be red or purplish because of the coloring, depends on what's underneath it. And then pustule, it's in the name, contains pus, so it's going to be yellowish in color and can really be any size, but usually under 5 millimeters. All right, here's a comparison of each of them. And you can see the pustule then is filled with pus. All right, then non-blister form, we have papule, which is small and solid. We have a plaque, which is going to be less than 5 millimeters in diameter, but it's going to be fairly smooth or corrugated. And you'll see this with people who chew. You'll see that corrugated tissue, and that's when we really start to get concerned because the tissue is changing, telling us that they're in danger. Okay. Then we have nodules, which is smaller than 1 centimeter in diameter and consists of solid tissue. And then a tumor, again, this is not relating to a neoplasm. This is just due to the size. It's 2 centimeters or greater in diameter and consists of solid tissue. Okay, other descriptive terms. Crust would be an outer layer covering or a scab that's formed from coagulation or from dried blood, serum, or pus on the outside. Erythema means red, and it doesn't matter the shape or size. Erythema is red. Exophilic means it's growing outward. Exo meaning out. Okay. Indurated is going to be hard. Papillary is resembling a small nipple-shaped projection. Petechiae are going to be those little tiny red spots of pinpoints. You'll see that sometimes on the buccal mucosa, or maybe even on the palate in some conditions. Then we have pseudomembrane. That's a loose membranous layer of exudate containing organisms, and it's precipitated fibrin, necrotic cells, and inflammatory cells produced during an inflammatory reaction on the surface of the tissue. A polyp is a mass of tissue that projects outward and upward from the normal surface level. Punctate is marked with points or dots differentiated from the surrounding surface by color, elevation, or texture. Then we have torus, which is the bony elevation or prominence usually found on the midline of the hard palate and the lingual surfaces of the mandible in the premolar areas. Verrucosus is a rough wart-like lesion. All right, here's an aphtha, and that is a little white or reddish ulcer. And then here you can see the crust after a herpetic outbreak. And then erythema, you can see in the lower picture how red it is along that gingival margin. Okay, so that would be erythema, the redness. Extosis is benign bony growths projecting from the surface of the bone. So much like torus, only these are going to be on your buccal surfaces. Okay. Idiopathic is of an unknown etiology. Indurated is going to be hardened or abnormally hard. And then lymphadenopathy is the disease of the lymph nodes, so regional lymph node enlargement. And again, we're going to be checking out these chains, these cervical chains, right? All right. Palpation is perceiving by sense of touch. Pedunculated, elevated lesion attached by a thin stem. So you can see in this picture, this upper picture, that it's a little thinner at the base. And so that would be pedunculated. All right, a polyp is a growth of mass protruding from a mucous membrane. So you might see this in the pharynx area. And then sessile is an elevated lesion with a broad base. Petechiae, you can see those on the palate here on the upper picture, and those are going to be the hemorrhagic spots with pinpoint to pinhead size. Purulent is containing, forming, or discharging pus. So if you look at this second picture, it looks like maybe a little pus is coming out there. There's a little lesion up above that I'm guessing is an abscess. All right, sclerosis is induration or hardening of the tissue. And then a torus, you can see in this bottom picture by the premolar area, are just those bony protrusions that are located on the hard palate, which is torus palatinus, and the lingual surface of the mandible in the premolar area, which is torus mandibularis, or mandibular tori. Trismus is a motor disturbance of the trigeminal nerve, especially spasms of the mascatory muscles with difficulty in opening the mouth. And you'll see that sometimes with administering some local anesthetic injections. Verruca is a wart-like growth, and we are seeing this a little more common lately. All right. Again, know your anatomy so you can describe where things are located. Intraoral examination, make a preliminary examination of the lips and the intraoral mucosa by using a mouth mirror or tongue depressor. Also make sure that you can see a nice vermilion border. You know, if it's if it's not well lined out, it could be due to sun damage. Okay, that could be a precursor to skin cancer. All right, torus is bulging or round projection and can be bone or muscle. You can see them all here. More recent research is thinking that it may be due to clenching. I don't know. All right, and then extosis is benign bony growth, and that is usually found in the buccal areas. Here's our extosis. You can see it in this first picture above that premolar. The upper picture on the right-hand side, you can see it above a lot of the posterior teeth, just those bony projections. And then that lower picture, that lighter pink area, is protruding. All right, then we'll often see these little tissue tags, and you know, they could be from a tear or just a variation of normal for a lot of people. You see these a lot. So it's just this little tag, this little protrusion on the frenum. All right, here we see petechiae again on the left side, and then you see petechiae looking, a petechiae appearance, I should say, with this nicotine stomatitis, and that's just from the heat of the cigarettes doing that to the tissue. All right, commissure lip pit, we talked about that a little bit in histology, where people can have a little pit right in the corners of their mouth here, and they can get very dry and chapped. They can also get angular chylosis, is pretty common with that, but really anybody can get angular chylosis. So just making sure that they are keeping up on there's chapstick on here, but really I recommend Aquifer because like it's so gentle and so effective on the tissues. All right, then here we have some low frenum attachments. You can see how the teeth in this upper left-hand corner, I'm gonna just try my laser. Oh, here we go. Finally decided to work. You can see how this frenum is coming down here, and what's happening is that frenum isn't allowing, that muscle attachment is so strong, it's not allowing these teeth to come together, and so that is what we call a diastema. Now, if we look over here on this picture with the arrow on it, you're going to see that that frenum attachment is a little high, and what's going to happen is you're going to get gingival stripping. That gingiva is going to start to recede due to that constant pull. On the lower left here, we have ankyloglossia, and that is a tongue tie, right, where that lingual frenum is attached to the tip of the tongue. Pretty common condition. Usually it's snipped at birth. This lower center picture, you can see a little bit of stripping of the gingiva there due to that constant lingual, that constant tug on that tissue. Okay, and here's another diastema up on the upper right, and then you can see the mucogingival defects from the gingival stripping with that higher lingual frenum. All right. All right, so you want to evaluate the pharynx. Note if it's red or swollen. This is a little red. This isn't, I mean, a lot of times, you know, if they're sick, it's going to be fiery red. And then tonsils. Are they present or are they not? You always want to ask your patient, have you had your tonsils removed? Some people don't think of that as a surgery when we ask it on the medical history, and that becomes a problem because then I'm constantly looking in there, and then I say, have you had your tonsils taken out? Oh yeah, you know, when I was like 6 years old. Well, okay, then I can stop looking for them, right, to double check them. All right, so are they present or not present? Are they enlarged or coated? You know, sometimes it'll just be food on there, but if they're coated, they may have strep. All right, then we get these little mucoceles, and if you guys recall what a mucocele is it's just a minor salivary gland that has plugged for some reason, and it is just fluid filled, and often people will try and just bite them open or will accidentally bite them open. Even if they're excised by an oral surgeon, they'll often come back again, but they usually burst, and then, you know, that's that. If they don't, then we need to refer them. Then we have our retromolar pad here, and it looks like the start of possibly an operculum here. All right, here's our ankyloglossia. You can see that this first patient, or this first picture on the left-hand side, the tongue can't touch the roof of the mouth because of that high attachment. And then you can see this is a true 100% ankyloglossia, a tongue tie on the right side. All right, then we have amalgam tattoos, and this is just often when either filling's being done or filling's being removed, a little speck of amalgam may have gotten in there, usually detectable on x-rays. This up here would make me suspicious of them they probably have a root canal in the tooth and then needed a retrofill. And that's usually where you see that. And sometimes in the past, amalgam had been used for that procedure. All right. And then here's our maxillary tuberosity. We want to make sure we know where that is located. We might see some scarring up in that area if a third molar's been extracted. Okay, so here we have a papilloma, and you can see it on pathology here. This is human papilloma virus. This is the worst I've ever seen. That looks pretty bad, but it's right there. Okay, I'm not sure what's going on with this tooth up here, but that doesn't look good. But this is a pretty large one, and it looks like little finger-like projections. It really does. All right, let's talk a little bit about oral cancer now. The oral cavity, the pharynx, larynx, paranasal sinuses, nasal cavity, salivary glands are all regions of the head and neck where cancer can present. Cancer of the head and neck begin as squamous cells that line moist mucosal surfaces of the mouth, nose, and throat. Salivary glands contain different types of cells that can also become cancerous. Because the early lesions are generally symptomless, they may go unnoticed or unreported by the patient. So observation by the dentist or yourself, the dental hygienist, is the principal method for detection of oral cancer. The first step is to examine the entire face, neck, and oral mucosa membranes of each patient at the initial examination and at each continuing care appointment. It is necessary to know how to conduct the oral examination where oral cancer occurs most frequently. You also want to know what an early cancerous lesion may look like and what to do if you find it, right? In addition to the early lesions, the oral manifestations of neoplasms or abnormal growth of tissue elsewhere in the body, as well as the oral manifestations of chemotherapy, can be recognized. Most oral cancers are related to tobacco or excessive alcohol use. Additional risk factors include HPV-16, and I'm also going to throw in HPV-18, but it is primarily 16. 18 is the next one, next most common one. Also, increase in age, anyone over the age of 40, and sun exposure to the lips all put people at a higher risk. All right, location. The most common site for oral cancer is the lateral borders of the tongue, the floor of the mouth, the lips, and the soft palate complex. Appearance of early cancer. Early cancer takes many forms and may resemble a variety of other common oral lesions. All types need to be examined with suspicion. 5 basic forms are going to be listed here. All right, so we have leukoplakia, and that is a white patch or it kind of looks like a plaque in there and cannot be scraped off. So when you see a white plaquey looking area, you're going to take your 2x2 gauze and see if it wipes off. Okay, leukoplakia cannot be scraped off. All right. It's characterized as any other disease. It may be associated with physical or chemical agents, especially the use of tobacco. I do want you guys to know that white areas do vary from a filmy, barely visible change to the heavy, thick, heaped areas of dry, white, keratinized tissues. So they can have fissures and ulcers of induration, so of hardness, in a white area, and are most indicative of malignancy. So white areas are more prone to be malignant. All right, then we have our red areas, and our red areas are erythro. Remember, erythro is red, right? Erythroplakia, just like leukoplakia is white, leuko meaning white, like white blood cells. So erythroplakia is a term used to designate lesions of the oral mucosa that appear as bright red patches or plaques. Lesions appear red or velvety in consistency, and that's what is kind of key, that velvety consistency. They may coincide with small ulcers. Erythroplakia is a rare precancerous lesion that cannot be characterized as any specific disease. Now, ulcers have flat or raised margins, but palpation of it you might feel something hard under there, so a little induration. All right, and then we have masses, papillary masses. Sometimes with ulcerated areas, it occurs as an elevation above the surrounding tissues. And then pigmentation. Brown or black pigmented areas may be located on the mucosa where pigmentation does not normally occur. Okay, and that's where we're looking at those squamous cell carcinomas. Okay, so for diagnosis, you can never diagnose cancer by looking at it, right? So we have these diagnostic aids for minimally invasive detection of oral cancer, and they include the brush cytology and telluride blue, diffuse tissue reflectance, and laser-induced autofluorescence. So all of these are kind of new. The brush cytology maybe not, and the telluride blue not as much, but the others are a little newer in the last 15 years or so, which is new in medicine. Alternatively, as designated by the dentist, a lesion may be biopsied immediately and sent to a laboratory for evaluation. Biopsy confirmation is considered the gold standard outcome. So you may do all of these, and these are just kind of there to help you determine whether or not a biopsy is needed, okay, because the biopsy is the gold standard. All right, let's talk about some of these tests. So exfoliative cytology is a minimally invasive approach to obtain cell samples for diagnosis of suspicious lesions. Okay, exfoliated cells and cells beneath the basal cells are removed by physical procedure such as surface scraping or brushing rinses or saliva specimen. Okay, a number of studies have been conducted to evaluate the different instruments used for obtaining cytology specimens. Basic requirements include easy to use, minimal patient discomfort, and collecting enough cells for evaluation. Basal cells are necessary to collect the ribonucleic acid to improve diagnostic accuracy. So you still need to get to that base, right? Except for candidiasis, treatment cannot be determined only by a smear technique results. After a positive smear, a biopsy is needed for definitive diagnosis. So know that, this is a really nice, easy way to get a quick biopsy. Then if it comes back positive, then you're going to send them for a true surgical biopsy. Okay? So a cytologic smear, the cytologic smear is a diagnostic aid in which surface cells of suspicious lesions are removed for microscopic evaluation by non-invasive means, such as a spatula or a brush. Cytology is used for identifying Candida albicans organisms in the patient with suspected candidiasis. Limitations of the smear technique include the smear detects only surface lesions. So you can't, if you feel something underneath, like maybe there's a tumor somewhere, it's not going to get to that, okay? It is difficult or impossible to scrape deep enough to obtain representative cells from a heavily keratinized lesion. And because research has shown that a smear technique is not diagnostically reliable, a negative report cannot be considered conclusive. So whether it's positive or negative, if it's positive, you're definitely referring them on. But a negative doesn't mean it's a true negative because maybe the cells weren't collected. Then we have liquid-based cytology. And the specimen and collection device are placed in a liquid preserve to create suspension of cells. The sample is then mailed to a laboratory for analysis. And then we have the oral brush cytology. And the brush cytology has grown in popularity in recent years. Special brushes are used to penetrate the lesion and to collect a sample of cells that include both surface cells and basal cells. The sample is then mailed to a laboratory for analysis. Despite the popularity of brush cytology, the conventional smear cytology has been shown to have a higher specificity and be less expensive. So the brush, like they said, is really popular, but the smear has actually got better results. Okay, spectroscopy. So this is laser-induced autofluorescence, and the laser-induced autofluorescence spectroscopy, sorry, I can say it, all of a sudden it's hard, such as Velscope, and please look that up. It uses wavelengths of light that cause the cells of an oral lesion to fluoresce. So you turn off the lights in the operatory, you shine it in the mouth, and then these cells will turn whatever color the fluorescent light is, okay, which I believe is green usually. So the accuracy is about 95.9%, and this doesn't, there's no discomfort for the patient here. So this is really, really nice. You do need to know your anatomy well. The limitation is that it's not effective for lesions on the lateral and dorsal surfaces of the tongue or the vermilion border of the lips. So the most common places, it's not great for, okay? Then we have diffuse reflective spectroscopy. See, I could say it there. Diffuse reflectance spectroscopy uses a fiber optic probe to direct light to suspicious lesions. Malignant cells are scattered light. They scatter light differently, so than normal cells, and so you'll see a contrast there. Okay, and this method is about 96.5% accurate in identifying possible malignant lesions. So we're improving little by little. Okay, so let's talk a little bit about the biopsy. And biopsy is removal and microscopic examination of the tissues that have been taken out of the body. All right, this is done by surgical removal and is considered the gold standard. So what are the indications for biopsy? Any unusual oral lesion that cannot be identified with clinical certainty. Any lesion that has not healed up in 2 weeks is considered suspicious. So that's why we always have our patient come back in 2 weeks. So it's suspicious for malignancy. Now, persistent, thick, white, hyperkeratotic lesions and any mass that does not break through the surface epithelium. Okay, so any mass that's hard, you're going to feel something in there. I guess it doesn't have to be hard, but if it doesn't break through that surface, then we're concerned. Now, the pathology report, if a report comes back and indicates class 3 through class 5 from a cytology smear, a biopsy is required. So here are the different classes. 1 is normal, 2 is atypical but not suggestive of malignant cells, 3, uncertain, possible for cancer, 4 is probable cancer, and 5 is positive cancer. All right, here's our leukoplakia. You can see this white patch here, and that you would definitely want it to be biopsied, and same with over here. Okay, see how it looks kind of like a plaque there, like they just didn't brush, right? So leukoplakia, leuko white plaque-ia. All right. All right, so here's our corrugated tissue. See how it kind of, corrugated means that it kind of looks like cardboard. If you take off the smooth surface, that part in between, kind of wavy. You can see chewing tobacco changing the cells here, okay? And then here you can see it kind of diffuse, all from chewing tobacco. Okay, and here's our squamous cell carcinoma. You can see it here, kind of protruding a little bit up here. Looks like possibly a little bit right there too, but it's hard to see. Okay, squamous cell carcinoma of the lower lips. Again, people who work outside, you know, make sure that you recommend that they use an SPF on their lips. So also if they golf a lot, if they're farmers, you know, anybody like that, always suggest that they wear a sunscreen on their lips. All right, and this looks a little harmless, right? But this is a basal cell carcinoma. Notice the little red center. It looks like it might be a little flaky there. So, all right, when it comes to documentation, we need to document everything. Of course, we always say that, right? So you need to document what source you used to obtain the cells. So every detail of the oral exam and follow-up procedures all need to be sent out to the consultants and the laboratories, and then they also need to be, another copy needs to be kept for the patient record. All right, any recommendations for frequency of complete oral examination at future dental hygiene maintenance appointments needs to be recorded. And then you want to review all lifestyle habits that may have provided a cause for the oral lesion. And then progress note representing the patient's first maintenance appointment following the incident of the biopsy, and learning the lesion was not cancerous may be reviewed in box 12-3. So you always want to make sure that the notes are in there. And the doctor is going to, once the pathology report comes back, usually the doctor will write up a note on the pathology report. So then you'll want to discuss that with your patient at their next visit. You know, how was your experience? How are you doing? Any changes since the last time we saw you? Okay. Okay. Record the record form for clinical findings. As part of the clinical exam, the record form is to note any deviations from normal and where they're at. So you can actually draw it on there. It's a nice form to have. Let me move my cursor here. It's very nice to use that. We actually don't have that. What's becoming more and more common now is the intraoral photos. And that's our documented record of where it's at. And then you can hold a probe up next to it so that you can see the measurement. And that's pretty effective. Okay, so here is some documentation in the SOAP notes of a biopsy that was done. So make sure that you know how to word it and what is all necessary in there, okay? So positive findings on intraoral examination, they list the location, what it looked like, the size, how it felt. It was non-mobile on palpation. Clinic is asymptomatic, so they aren't showing any signs with no associated lymphadenopathy. A client has been informed and will return for follow-up in 2 weeks. Possible biopsy or referral to oral surgeon if the lesion does not change in nature or does not resolve. Okay? So, and then you would have another note at the next visit, right? In 2 weeks. I also keep a list of people, like a little calendar reminder of people that I need to call to follow up because they may cancel their appointment or maybe they don't schedule it on their way out and then it slips their mind. Okay? Okay, and this is the form that we used to have before we went to all of our rubrics online. I think I gave this to you guys. Maybe not. You'll get it in pre-clinic, but it does have a nice, findings chart where you can mark exactly where everything is. But unfortunately, now everything is digital, so we don't have this capability. That should be a suggestion to EagleSoft to have photos in the head and neck tabs. But again, we can use intraoral photos, right? Everybody's got the intraoral cameras now. Let's see here. All right, here's some additional information for you. All right, let's review factors to teach the patient. Reasons for careful extraoral and intraoral examination at each maintenance appointment. Guidance and support on tobacco cessation should be provided when the patient is interested, especially if they're asking for a referral. How to conduct a self-evaluation for the patient in the months while they're not in the office. Also, to help them identify the lesion that's in their mouth, right? If it's going to be a little longer than 2 weeks. Examination includes face, neck, lips, gingiva, cheeks, tongue, palate, and throat. All right, any changes are reported to the dentist and the dental hygienist, so they would have to call that in. Again, I would call them back. All right, so they should be doing this on a monthly basis, especially if they have a history of cancer. And then you want to counsel them on what the lesions would look like, right? You know, how to describe them. And then, you know, dietary and nutritional influences, we want to make sure that they have the proper nutrients to prevent any lesions. And this doesn't necessarily mean cancer, right? We're going to be talking a little bit about diet later on and how it reflects what we see in the mouth. So eating a diet rich of fruits and vegetables is really going to be quite important for the patient. Oral cavity reflects general health. We want to let them know that there is a strong correlation between the oral cavity and everything else that's happening in the body, and vice versa. What's happening in the body can often reflect on what's happening in the oral cavity. And then we want to notify them of signs, warning signs of oral cancer, such as numbness and tingling, excessive dryness or wetness, prolonged hoarseness or sore throats, especially if they're persistent with coughs and they aren't on lisinopril, or the feeling of a lump in their throat, difficulty with swallowing, and difficulty in opening their mouth. White patches or red velvety areas, any sores that don't heal within 2 weeks. So let your patient know when you see something in there, hey, we need to monitor this without alarming them too much, right? Because most of the time it's not going to be anything, but we just want to take a look at it, right? Just to be sure it's nothing. All right, if you have any questions, please let me know. Thank you.